عايزه اتاكد بس انه دكتور اشرف هو هيبقى بعت له لينك عشان هو هيبقى معانا فيرجن عايزه اتاكد ان هو دخل بيقول لي دخل دلوقتي عشان هو
مايك. دكتور أشرف حضرتك سامعني؟ دكتور أشرف فين؟
هو قفل المايك اصلا.
دكتور أشرف حضرتك ممكن تفتح المايك، هي القاعة فاضية احنا لسه بدأناش. أطمن بس إن حضرتك كونكتد تمام. دكتور أشرف
هو ممكن يكون اقرب يعني مش
أشرف، أنا بحاول أكلم حضرتك من القاعة فاضية يعني عشان نطمن من الصوت والكونكشن وكل حاجة، فحضرتك عامل ميوت تقريبا.
انا كده حضرتك سامعاني كده؟ انا فتحت الميوت يا دكتوره منى. حضرتك سامعاني؟
حضرتك كويس، سامع حضرتك كويس تمام يا دكتور أشرف. طيب هو احنا هنبدأ 3:30 ان شاء الله. اول محاضرة بعد الانترودكشن هتبقى دكتورة رشا، وبعدين حضرتك على طول بعدها.
توكلنا على الله.
شكرا دكتور أشرف.
حضرتك اهلا بيكي.
زي انا كويس يعني مش حلوه قوي عشان في كده على الظهر احنا ممكن ده بسهوله كده احنا ناخد مش محتاجين حد من الفندق
هم اصل احنا كده التشير بيرسونز 4. اقعد ادور على حد help yourself يعني. احنا كده مين اللي محمد سعيد زمان مين اعتذر؟ دكتور اشرف عمر معانا فيرشن ان شاء الله. وكده الرابع محمد سعيد.
انا متابعه.
تفتكر؟ يعني هي دي
انا مش عارف قصه
نجلاء موجوده بتصلي وايمان وانت فاضل محمد سعيد. لا خلاص كده
خلاص كده مظبوط.
انا ممكن اقعد انا هنا مش مشكله.
طب ليه؟ لا حضرتك اقعدي.
انا هقوم واقعد عشان حطيت شنطتي هناك عشان ابقى جنبي.
يعني عامله 2 مينتس 12 مينتس 17 مينتس.
يعني اقصد ان انا هقوم اقعد كذا مره.
لا
مش
قصدي
مشكله لو ما جاش حد رابع اقعد معاكم.
المحاضرات انت عاملاها
مفيش مكان اصلا.
عاملاها رتيب محاضرات
قليل.
لا كويس بدقيقه قصدي بدقيقه بس يبقى يمشوا على كده بس.
هم بيعملوا تايمر يعني امبارح كانوا كده ويقوموا
بتوقف.
لا بيوقف. هو بيوقف كتايمنج سكند لكن ما بيقفلش عليه.
طبعا
دي لطيفه يعني برضو حاجه كويسه. هو طبعا هنا مشكله في ده انه السلم انا عايزه اجيبه كده امبارح عشان الواحد يعدي كده يروح لل ايه اللي منهم مش فيرشن يعني كده لطيف. دكتور شريف سجلها وبعتها لهم متسجله وهيبقى معانا اونلاين. دكتور مصطفى الشاذلي بعت كريم حسني مكانه وهيبقى معانا اونلاين. ربنا يعافيهم جميعا. ايه؟
المؤتمرات دلوقتي بقت ايه؟
Did you experience قبل كده؟ انا شفتها في الويف الثانيه تقريبا. انا قعدت شهر. انا يعني كنت في الارض بس دلوقتي تجربه الطف يعني. هي الاوميكرون ده على قد ما هو
هي بتيجي بقى
unexpected. دلوقتي ناس كتيره جدا بتحلل اسباب ثانيه وتطلع فاضي يعني اللي مسافر.
في ناس اسيمتوماتيك.
انا ناس كتيره جدا بتكلمني احنا كنا مسافرين وطلعوا يعني هم مش
هو
مفيش اي مشكله.
يا ابر ريسبيراتوري خفيف كده وراني نوز وبتاع يا اما اسيمتوماتيك خالص.
بس في العيله كلها معاك مثلا
هو مثلا بشكل بشع.
الناس اللي هي بتتعامل وسنها كويس مش وحشه. انا عندي ناس للاسف ناس في السن صغير.
اكيد التطعيم بيفرق. انا خدتها قبل ما اتطعم خالص. انا واخده دلوقتي ثالث جرعه يعني البوستر خدته او واخده اصلا يعني على اصول. انا واخده الاثنين الاولانيين استرا. انا مت في كله. كان مؤتمر ساعتها عملته من البيت. انا كنت متبهدله
من
المؤتمر بتاعنا الفاكسين. ميني كورونا. انا كنت قاعده يومين في السرير 48 ساعه بالظبط. مش فاكره كانت اول جرعه. انها كانت في فبراير المؤتمر بتاعنا بتاع القصر. الجرعه الثانيه خدتها في 5 كانت استرا برضه تعبت بس يعني مش فظيعه قوي. خدت بقى البوستر فايزر على اساس انها مش هتتعبني موت.
انا مش عارفه والله
مع ان عمري ما تعبش عادي.
في فاريشن غريبه قوي. انا بنتي خدت الفايزر ده ولا حاجه خالص ولا
ولا حاجه.
انا قلت لا ده اكيد بايظ. لا انا قلت هو اكيد التطعيم يعني مضروب مش طبيعي. لان هم حاطينه في ايس بوكس كده. هو المفروض يتحفظ في ماينس
60 تقريبا او 7.
فهم جايبين معاهم في
الايس بوكس ده بس عشان يطلعوا من الثلاجه للحته اللي انت
والله انا قلت اكيد بايظ.
ما خدتش حاجه خالص.
اللي ايه خدت ايه؟ برضه مش كل الناس يعني بس في ناس تعبت.
في ناس تعبت. شكيت حاجه في البيت بيديهولي لو قلت كوسه كده كنت كده على جنب بسرعه تعبت اجيب.
لا هي واضح انها حاجه فيري انديفيدواليز بشكل غريب. اعملوا ديستنس لبعض.
ما انا حد جه مش كده هنقعد.
هو كله هيبقى اونلاين بقى.
هم حضور بس.
انا هكلم محمد اشوف
ما غيرش حضرتك يعني انا عمليه نفس التجربه مش حاجه ما عملتش برضه اسهل المسكات مبهدله
كله كويس؟
الحمد لله كنا في لجنه البرين
كله وقف خلاص.
ليه دلوقتي عاملين سيشن بحالها هتكون بعرض اهي الكلام ده
ابراهيم مصطفى والله كنا عاملين شغل حلو جدا.
كنا نعمل علشان نبتدي برنامج الديسيز دونر. ايوه
حضرنا حاجات، رحنا السعوديه وقعدنا في السعوديه، قعدنا هناك اسبوع هناك مع السعوديين عشان نعمل البروجرام بتاعهم. كان
والله بيتكلموا عن القصه دي.
قصه بقى 10 سنين، قصه 10 سنين
10 سنين قبل ما اخلف 11 ما كنتش لسه خلفت.
كنت ساعه بريجننت
اي فاكر حضرتك
كانت بيجي علينا ووزاره الصحه ما كانت ابن الذين كنا نقعد في الاجتماعات فيه. كان معانا الخمس بتاع كده.
ايوه بس انا ما اقدرش اتكلم، مش هلحق البروجرام
كان معانا الله يرحمه الدكتور بتاع الكلى ده زي بتاع مش
ايوه دكتور حسين شعيشه الله يرحمه.
كان اكتف جدا وكان شاطر جدا وستو يانج يعني.
خمسينات هو.
اتفضل انت عندك كلمه يا ميمه. انا مدي لكل واحد هيقدم مين؟
انا هقدم دكتور عمر. دكتور عمر عبد العزيز.
ماشي، انا هقدم دكتور شريف مجاور، وبعدين دكتوره منى بعت لي كل واحد هيقدم حد.
ايوه هو دكتور شريف مجاور ده مش
كويس جدا.
مش شايف المستوى
لا ده محمد، لا محمد مش شريف مجاور، محمد سعيد.
ده محمد سعيد. محمد سعيد صح، لما اتكلم عرفت. دكتور محمد سعيد
ازاي؟
ده حاجه فعلا فرحك ايه؟ الحمد لله والله ربنا يبارك حضرتك. الله يخليك.
دكتور محمد
ازي حضرتك يا فندم؟ اهلا وسهلا. ازي حضرتك؟ عامله ايه؟ ازي حضرتك يا فندم؟ اهلا وسهلا. ازي حضرتك؟ مساء الخير.
مش تبعنا؟
ايه؟
حضرتك شيف بيرسون.
على جنبي
يعني حضراتكم يعني مدعوين عندنا برضه في اسم 2 ان شاء الله. يعني فرصه ان احنا نتقابل النهارده بدل ما عملوا ايه ازعاج.
تعالي بقى.
ده 22 فبراير تقريبا.
لا
انت
11 مارس ان شاء الله.
مؤتمر بركاته.
كريم زي حضرتك دكتور كريم
كريم زي حضرتك مركز الصيام. كريم
انت عارف دكتور مصطفى مش هيجي صح؟
انا عارف.
طيب وانا هقول مش بداله.
خلاص ان شاء الله.
تبتدي 12 مارس
11 مارس ان شاء الله. مؤتمر اسم الامراض المتوطنه في جلسه
يوم جمعه.
يوم جمعه ان شاء الله. دي جلسه عن الليفر ترانسبلانتيشن. حضرتك شايف ان شاء الله.
شفت المسافه مش مارس.
لا
هيك تشرفينا ان شاء الله. 11 مارس في جلسه عن الليفر ترانسبلانتيشن.
حضرتك المودريتور؟
انا المودريتور. ماشي معتز هيك معانا.
الأسرعين برضه مش فاهم. الأسرعين
الأسرعين ولا جوه الأسرعين نفسها اللي هو اللي هو الليرنينج سنتر هناك.
ايوه
بس نبتدي على طول عشان ايه بس الجو ما يعطلك.
الجلسة عليك method real life practice and future perspectives.
اوكي
عشان نمسك جلستين طويلة انا اسف جدا.
طب كان يفوت ازاي حضرتك
الوش على انا اصلا انا عارفاكي الدكتوره احمد حلمي دايما الدكتوره مجلاء عندنا والله ايوه بس دكتور حلمي في السعوديه طب ايوه اخباره ايه؟ مسافر برضه يعني رجع شويه وسافر تاني هي اسمه موجود النهارده؟
لا اسمه كان موجود امبارح جلسة النيوتريشن. الأجهزة اللي هي حضرتك بقى وزيدة 8-3
طلع لي بس لسه ما جاليش الواتساب مسج صح؟
سمعت تقريبا يعني؟
لا بس هندخل
نفتح
ورق
انا بديت في المطر بس انا من شويه
جامد يعني
لا ما كانش
يعني طبعا يعني
لسه برجع
بسم الله الرحمن الرحيم. I have the honor to be with you today moderating this session, Post-Operative Challenges in Recipient Management. Let's first welcome together our distinguished chairpersons from different centers of liver transplantation and different institutes across our country in alphabetical order. Professor Iman Fawzi Montasser, Associate Professor of Hepatogastroenterology and Infectious Diseases, Ain Shams University, and Senior Consultant of Hepatology, Gastroenterology, and Liver Transplantation, Ain Shams Center for Organ Transplantation. Professor Muhammad Saeed Abdelaziz, Professor of Hepatogastroenterology and Endemic Medicine, Cairo University, and Consultant of Liver Transplantation, Cairo University, and Director of Viral Hepatitis Center. Professor Mu'taz Siam, Professor of Hepatogastroenterology, Head of Clinical Medical Department, Yador Bilhars Research Institute. He's trained in Liver Unit, Queen Elizabeth Hospital, University of Birmingham, UK. He's a member of the Higher Committee for Organ Transplantation in Egypt. He's also a founding member of liver transplantation units at both Egypt Air Hospital and Yador Bilhars Hospital. Professor Nagla Alam, Professor of Hepatology, National Liver Institute, Menifee University, trained at Liver Transplant Department, University of Pennsylvania, USA, and worked at Liver Transplant Unit in King Faisal Hospital, and also one of the team of transplantation program at the National Liver Institute. Liver transplantation, as we all know, remains the treatment of choice for the patients of many patients of end-stage liver disease and acute liver failure. While early post-liver transplant 1-year survival rates have essentially improved to over 80%, this does not seem to apply equally to the long-term outcome. The 10-year patient survival data obtained from 2 different time periods, 1990 to 94, as well as 2005 to 7, did not improve, with 60 and 61% only, respectively. In fact, long-term survivors are at continued risk of increased morbidity. In addition to classical transplant-related complications such as graft dysfunction, rejection, or liver disease recurrence, the late mortality is also due to factors that are independent of graft function. Metabolic complications, cardiovascular disease, renal dysfunction, as well as extrahepatic malignancies play a major role in the long-term morbidity and mortality of liver transplant patients. Improving long-term patient as well as graft survival after liver transplantation remains our major challenge. So our session is concerned with discussing some of substantial challenges we may face while managing our recipients post-transplant and how to deal with sharing together expert opinions and experiences of different liver transplantation centers. We'll go through 4 main challenges in our session: subclinical rejection and role of protocol biopsy, target therapy for HCC recurrence and how to use, PRES as an unusual neurological complication, and the dilemma of cholestasis post-liver transplant, followed by discussion for 8 minutes at the end of the session. Challenge 1, subclinical rejection and role of protocol biopsy, will be presented to us by Professor Rasha Rifai, Professor and Head of Internal Medicine Department, Helwan University, Consultant of Hepatology and Liver Transplantation, Executive Director of Liver Transplantation Unit, Wadi Nil Hospital, and as we all know, one of the eminent names and of the pioneers in the field of liver transplantation. Professor Rasha.
Thank you so much, Professor Mona, for the nice introduction. Actually, this session is very nice, and what I like most that we will share the experience and it's something from what we meet during our everyday experience and in our programs. I am going to present a case, and actually this case is the case that triggered me to talk about this subject today. This is a male patient, 20 years old. He had a living donor liver transplantation in 2007 for congenital hepatic fibrosis. He was maintained on MMF and Prograf, and he was doing fine. In 2015, he was diagnosed with non-Hodgkin lymphoma, PTLD, and his Epstein PCR was positive at that time. His cervical lymph node biopsy showed diffuse B-cell lymphoma of non-germinal center type. As I said, it was associated with Epstein-Barr infection. His PET scan was positive for cervical, subclavicular, infraclavicular, and all the mediastinal groups of lymph nodes. At that time, all his immune suppression was stopped, and he received 4 cycles of rituximab, cyclophosphamide, vincristine, and prednisone. He ended his treatment in January 2016 with complete remission. Since then, he was off immunosuppression. His follow-ups were all done in the pediatric transplant hepatology clinic. He presented to us in the adult clinic in October 2021. He presented with completely normal liver profile labs. His bilirubin was total 0.8 and direct 0.2. His transaminases were 38 and 38, alkaline phosphatase 65, gamma GT 61, and serum creatinine 0.9. His ultrasound was normal. At that time, his father asked me a question. He was coming to the clinic to ask, should I keep my son off immune suppression or should I resume immune suppression? I just want to know from the floor and chairperson, what do you think if you have such a patient with such a liver profile? Keep him off? Okay. Any opinions from?
You ask the oncology.
You
ask the oncology. The situation of his B-T lymphoma, there is a risk of reactivation of this complete remission.
Okay. So, as Professor Mucosal said, there is a concern in this child for the PTLD, and there is another concerns also for rejection, keeping in consideration his young age. So I decided to do liver biopsy because it's easy for this child without having any idea to keep him off immune suppression. But for me, if he was older age, I would have taken this decision to keep him off. But he is 20 years old and I was afraid to lose the graft. So I decided, because it was a very difficult question for me, I decided to do a liver biopsy. And actually, when I decided to do the liver biopsy, I was expecting 90% that it will be normal. Why I considered the biopsy? Because of the young age, as I said, of the recipient. Considering the history of PTLD, I was preferring to keep him off immune suppression. But the problem that we used to see the pediatric age group, they used to do protocol biopsy. And the histological abnormalities, including chronic hepatitis, chronic rejection, fibrosis, and steatosis, are reported in the biopsies of these children after liver transplantation. And these changes may be progressive and represent a form of rejection. And usually this liver biochemistry of these children were normal when they did this biopsy. And this was the initiative for me to do the biopsy. Unfortunately, the biopsy came with early ductopenic rejection with fibrosis in 20% of the portal tract. Or maybe it's not unfortunate, maybe it's fortunate that we did the biopsy. This is the biopsy. I don't know if it is clear or not. The biopsy showed early ductopenic rejection with fibrosis in 20% of the examined portal tracts. And the C4D was negative in this child, so no fear of the donor-specific antibody rejection. So what's next after this biopsy? What do you think?
resuming the immune suppression.
Okay. So my decision was to resume the immune suppression, but I was afraid for this case about the PTLD. I decided to put him on monotherapy with long-acting Prograf, the Advagraph, and we started 1 milligram Advagraph. We did this for better compliance because we should consider that he was a child, he was off immune suppression for more than 6 years, and at this stage it's very difficult for the patients to shift from the pediatric hepatologist to adult hepatologist clinic. Psychological, it's difficult, and then he comes, I tell him we have to do biopsy, we have to take medication. So I considered the compliance. That's why I started with him the Advagraph. Also, I considered the history of the PTLD. I kept him on a very low dose of trough level. I was considering all the time optimizing the immune suppression to balance between avoiding the rejection and having side effects in such a young patient. And we decided to do protocol biopsy to evaluate the histopathological changes and to see if it will proceed or reverse. And we were fortunate that we discovered it early enough. As we all know that the liver allograft is uniquely immunological privileged organ and can be transplanted successfully despite the positive cross-match irrespective of the HLA matching. Liver transplant requires less amount of induction therapy and maintenance immune suppression compared to other organs. And the features of chronic rejection rates are low even when immune suppression are minimized or absent. But still chronic rejection is there. Chronic rejection of the liver is immunologically mediated. Insult to the parenchyma resulted to damage of the vessels and the bile ducts. The prevalence of chronic rejection after liver transplantation has been declining over the last years, mainly due to the introduction of the new potent immune suppressive regimens. However, when chronic rejection occurs, it may be successfully treated only in the early phases, while irreversible injury may lead to graft loss requiring retransplantation. Despite being a post-transplantation complication that has been recognized for a long time, its pathogenesis as well as its clinical implications and treatment are fields that still require full understanding. The chronic rejection is a consequence of activation of the host immunity system against the liver allograft and can occur through two general mechanisms. The first and the most common in the liver is the T-cell mediated chronic rejection, and it is a long-known complication of liver transplantation. Then the antibody-mediated chronic rejection instead has been observed initially in the heart and the kidney transplants, yet it is thought to spare liver allografts because the liver is relatively immune privileged organ and is commonly not targeted by antibodies. But today it is known that that antibody-mediated chronic rejection affect liver allografts as well, and with not so clear clinical consequences. Nonetheless, the condition can evolve to graft failure and death. Therefore, it is of paramount importance to progress in the prevention, early diagnosis, and specific management of chronic rejection. Talking about the risk factors for the chronic rejection, there are some risk factors among which is history of T-cell mediated acute rejection episodes. And actually in this case, when I revised the history of the patient, I found that he had 2 episodes of acute rejection. Second, the autoimmune etiology of the primary disease, non-compliance with immune therapy. This is a big issue. The cyclosporin-based immunosuppression regimens as opposed to tacrolimus-based regimen, the previous retransplantation for rejection, donor recipient gender mismatch, and actually this was of interest when I was revising the literature. We never have seen this or tried to see if we have this in our patient. Donor age greater than 40. Immune suppression drugs play a crucial role in influencing the onset of the chronic rejection. After liver transplantation, the immune suppression is considered as which maintains the viable graft and healthy patients, balancing the risk of rejection and the risk of side effects. Yet different strategies are currently adopted depending on a large number of variables such as recipient renal function, the cardiovascular diseases, risk of infection, tumor, and recurrence of the underlying disease. Nevertheless, there is a unique definition for the optimal immune suppression since it should be tailored to each recipient. About protocol biopsy, they are done less frequently in the past than in the past. This is because the lack of consensus regarding the use of protocol biopsies are due in part to the risks associated with the procedure, are certain uncertainty about the usefulness of these biopsies in patients with normal liver function tests. We are always hesitant to do the biopsies, even if the labs are elevated. So when we face such patients with normal liver, it's very difficult to order a liver biopsy, and it's also very difficult to convince the patients to do them. Part of the rationale for the protocol biopsies was the need to understand the range of histological findings in the normal allograft and the histological and clinical correlation. This was a study done in Essen in 2021 for protocol liver biopsies in stable long-term pediatric liver transplant recipients, risk or benefit. And it revealed a high prevalence of graft fibrosis, 67%, and graft inflammation. The graft inflammation was significantly more frequent within the first 5 years after transplantation compared to later points. So they concluded that protocol liver biopsies are safe and a useful tool to detect silent immune-mediated allograft injuries in the context of normal liver parameters. Finally, my take-home message is that chronic rejection may be silent without any biochemical changes in the liver function tests. The pathological changes always precede the biochemical changes, sometimes for years. Early detection of the chronic rejection is reversible, or at least we can keep the stage of injury to the bile duct at the stage that we discovered it. Silent immune-mediated allograft injuries are underestimated. Protocol liver biopsies should be reconsidered, especially with the lack of cadaveric programs and the limitations of living donors. Protocol liver biopsies are safe and useful to detect silent immune-mediated allograft injuries in the context of liver parameters. Thank you so much.
I have only one comment for the Dr. Rachel. Okay. I have the honor to introduce my dear Professor Dr. Ashraf Omar. He's a professor of hepatology and liver transplantation, and he's consultant of liver transplantation at Cairo University, president of the Egyptian Society of Liver Cancer, and the head of Middle East and North Africa Committee for HCC, the board member of African Hepatopancreatic Biliary Cancer. He is online with us. He will present the target therapy for vascular carcinoma post liver transplantation, how to use.
Assalamu alaikum. It's really my pleasure and honor to be with you today. Unfortunately, it was virtual. It is virtual. First, I would like to thank Professor Dr. Mona for inviting me to be with you in this distinguished conference. The challenge number 2 is, I hope my voice is okay.
Yes,
السلايدز الصورة واضحة والصوت واضح؟
اوكي واضح يا دكتور اشرف.
Yes, it's clear.
الصوت واضح لكن الصورة هي اللي مش موجودة.
السلايدز مش واضحة؟
دلوقتي السلايد واضح بقى.
واضحة خلاص؟
واضحة يا فندم.
واضحة يا فندم.
Challenge number 2 is the target therapy for HCC recurrence post-liver transplantation, and really it's a challenging problem. When you know that liver transplantation has emerged as the preferred treatment for early stage of liver cancer because of dual benefit, removing of both the primary tumor and the underlying tumorigenic cirrhotic environment, which results in favorable disease-free survival. As we all know, the gold standard is the Milan criteria. It's a gold standard for selection of HCC transplantation patients for liver transplantation to minimize the HCC recurrence rate. Recently, more centers worldwide are transplanting patients beyond Milan criteria based on various extended transplant criteria, and also downstaging via different local regional therapies from beyond or to within Milan criteria. All these may increase the risk of recurrence post-liver transplantation. And despite all the careful selection, up to 60% of patients who fit strict radiological criteria are incorrectly stages until explant. 6 to 18% of transplanted patients develop HCC recurrence. The median survival is from 10 to 13 months following recurrence. And the graph is showing the recurrence rate in a big study, more than 100 cases, and seeing the post-HCC recurrence, evaluating the post-HCC recurrence survival. And as we can see, the first year survival is up to 57% and 17% after 7 years. The nature of the recurrence can be highly variable, often present with extrahepatic involvement. Most of the time, the recurrence is associated with extrahepatic metastases, mainly in the lung, liver, bone, lymph nodes, and the management are really challenging because there is no consensus guidelines. What about the factors that may predict recurrence? The preoperative biopsy may be associated with small significant risk of seedling and micrometastasis. Of course, the burden of the immune suppression may have also contribute to the risk of HCC recurrence, and some trials to anticipate tumor recurrence by evaluating the circulating tumor cells or cell-free DNA. These are ongoing trial till now. The proposed proposal is surveillance imaging with contrast enhancing CT or MRI at regular intervals for the first 2 to 3 years after transplant. Serial alpha-fetoprotein determination are useful to track post-transplantation. Of course, a rising alpha-fetoprotein in patients who had a prior elevated alpha-fetoprotein should prompt a careful search for recurrence, including in extrahepatic sites. The ASLD recommended the use of a prognostic score, which is called retreat score, which is for estimation of tumor recurrence after transplantation, may help stratify those patients at high risk for recurrence and individualize their surveillance strategy. The retreat score ranges from 0 to 8, with decreased post-liver transplantation survival at 3 years in patients with increasing the score. And here is the score, which depends on the serum alpha-fetoprotein from 0 to 2 to up to 1,000, and score from 0 to 3. The presence of microvascular invasion, the tumor grade and differentiation, and the size of the tumor. Each, according to this table, is having a score, and according the higher the score, the higher the risk of the recurrence. And here are summary of the existing prognostic risk scores: the retreat score, the alpha-fetoprotein level, French score, which is presented 2011, train score, morale, and so on. I think the retreat score, which has been recommended by the ASLD, is now on charge. What about treatment? The treatment is very challenging, and we have to consider three main issues: the systemic therapy, the immune suppression management, and the new immune therapy. Regards the systemic therapy, as you know, the multikinase inhibitor, which has been introduced in the market 2008, is a multikinase inhibitor that showed survival benefit in patients with this disseminated recurrence of hepatocellular carcinoma after liver transplantation, median survival of 12 months. But it is also associated with some drug limitation because of drug toxicity. The second line is regorafenib, is also maybe used as second-line treatment after sorafenib failure, while a small retrospective case control match study suggested possible benefit of sorafenib as an adjuvant therapy in high-risk patients after transplantation. However, the phase 3 double-blind placebo-controlled trial failed to show any benefit in HCC recurrence. So using sorafenib as an adjuvant is not recommended. Here are the trials which has been used sorafenib as meta-analysis or retrospective cohort or case series using the sorafenib with mTOR inhibitors with the overall median survival ranging from 5 to up to 20%. One of the most important issue in the management of hepatocellular carcinoma post-liver transplantation is the immune suppression, the calcineurin inhibitors, of course, related to direct inhibition of the immune system, thereby hindering detection and eradication of the circulating cancer cells and might increase the risk of recurrence. By using the mTOR inhibitors like sirolimus or everolimus, which may have anti-neoplastic property, as you know that mTOR inhibitor is blocking one of the important signaling pathways that might involve it in the evolution of hepatocellular carcinoma, may hypothesized to reduce the rate of HCC recurrence. However, a prospective phase 3 multicenter randomized trial failed to show any benefit in HCC recurrence rate in transplant recipients treated with sirolimus compared to sirolimus-free regimen. Using sorafenib with sirolimus, which may have a synergistic effect, has also been proposed in patients with recurrent HCC. However, there is currently insufficient evidence to recommend this broadly. A recent meta-analysis compared everolimus and sirolimus showed lower recurrence rate in patients with everolimus compared to sirolimus or calcineurin inhibitors. Here are the trials using the mTOR inhibitors, 5-year survival, overall survival, which is disease-free survival, using the mTOR inhibitors with promising overall survival. And here is the survival factors according to the regimen of the treatment: tyrosine kinase inhibitor alone, tyrosine kinase with mTOR inhibitor, and medical plus other treatment modalities. And as we can see, the highest survival rate is the combined therapy mTOR inhibitor with the medical treatment. What about the new immune therapy in the treatment of hepatocellular carcinoma recurrence? The problem is there is some concerns using immune therapy. Immune therapy regulates cell-mediated immunity, which can interfere with the post-transplant immune tolerance and contribute to treatment-resistant allograft transplant rejection. There is a sensitive balance between tumor recurrence and the progression with graft rejection or failure. Recently, there is a very rare data about the use of immune therapy post-liver transplantation. However, one of the retrospective pilot study from Mayo Clinic showed some benefit. However, 2 of 7 patients developed allograft rejection. So further studies are needed to investigate the efficacy and safety of immune therapy in the treatment of post-liver transplantation recurrence. Here are, in this table shows the ongoing clinical trial using the immune therapy, immune checkpoints, the anti-PD-1 and anti-PD-L1, the program cell death 1, in using this immune therapy in the post-transplant setting for hepatocellular carcinoma recurrence. Here are some of the data using the immune therapy, old immune data regarding the recurrence of hepatocellular carcinoma after liver transplantation. And as we can see, there is a large number of patients got rejection after taking this immune checkpoint inhibitor. So at this point, immune therapy in the transplant population can't be recommended, though future clinical trials are currently underway. So to sum up, if patients after surveillance by CT and or alpha-fetoprotein and got HCC recurrence, and this schedule should be every 3 to 6 months, yearly, at that point of recurrence, we have to go for 2 important steps. Number 1, staging workup. Number 2, reassess the immune therapy of the patients. We have to decrease the calcineurin inhibitors and increase the mTOR inhibitors. And according to the staging workup, we have 2 main options. If you have a disseminated recurrence, so we have to start with the systemic therapy with sorafenib, the tyrosine kinase, sorafenib, or regorafenib, or lenvatinib, and we have to close monitoring the graft function and any side effects. If the recurrence is in a way limited, the resection and ablation regional therapy may be considered. So this is the algorithm that we can use nowadays in patients with recurrence post-liver transplantation. And in conclusion, HCC recurrence after liver transplantation occur in a significant number of patients despite the adherence to strict selection criteria and can be challenging on management. Calcineurin inhibitors such as maybe contribute to increase the risk of HCC recurrence. Use both sorafenib and sirolimus, which may have a synergistic effect, has also been proposed in patients with recurrent HCC. However, there is currently insufficient evidence to recommend this protocol broadly. And thank you very much.
Thank you very much, Dr. Ashraf, for this excellent and comprehensive presentation.
It's now my pleasure to introduce Dr. Amir Awad, the lecturer of hepatology and gastroenterology, internal medicine, Cairo University, and one of the active team members in the at the unit of transplant unit at El Manial Hospital, Cairo University. Dr. Abir will talk about the unusual neurological complications.
Thank you. It's my great pleasure to participate in this fruitful session. And many thanks for my dear professor, Dr. Mona Al-Amir, for this kind invitation. I will talk about PERS syndrome as unusual neurological complication. My case is 64 years old male patient who underwent living donor liver transplantation for recurrent hepatocellular carcinoma within the Milan criteria. His child B and mild was to be diabetic or hypertensive, and his PET CT scan was normal 1 month before the transplantation. His donor was his sister, 40 years old, with no past medical history, and her body mass index equal 27, and liver biopsy showed 10 to 12% steatosis, with GRWR equal 0.8%. The patient ran a smooth post-operative course till the day 11 post-transplantation, when the patient developed sudden painless left upper limb weakness, grade 0, and shortly after an attack of status epilepticus started and followed by disturbed conscious level. His glaucoma scale at the time was less than 8. The patient readmitted to the ICU, sedated and mechanically ventilated for 3 days. Convulsions were controlled with anticonvulsant treatment and continuous infusion of midazolam. After that, the patient progressively regained normal conscious level and weaned from the mechanical ventilation. Following the regaining of conscious level, the patient discovered to have bilateral blindness. His neurological examination revealed bilateral complete loss of vision with left upper limb monoplasia. And ophthalmological examination revealed no light perception for both eyes. Pupils were non-reactive and pinpoint. Extraocular muscle, intraocular tension, fundus examination, and slit lamp examination all were normal. So at this time, our differential diagnosis is it metabolic cause, infectious cause, central cause, or maybe drug toxicity. The patient initial lab workup, including complete blood picture, chemistry, including electrolytes, complete liver function, kidney function, thyroid function tests, are within the normal range. Bank culture were also negative. So we excluded metabolic and infectious cause. His current medications was tacrolimus 2 mg twice a day since day 1 of transplantation. And tacrolimus blood level was 8.12 nanogram per milliliter at the time, which is within the therapeutic target level. Still, drug toxicity may occur within the normal range. Proceeding with imaging, the CT brain with contrast was normal. MRI and MRA revealed bilateral multifocal cortical and subcortical areas of prior T2 and flare signal intensity in the occipital and frontoparietal region. They show no diffusion restriction on diffusion weighted image and acoustic diffusion coefficient map. This is the MRI and the MRA of our patient. Those changes were consistent with atypical radiological features of posterior reversible encephalopathy syndrome. And after proper evaluation, our patient was not hypertensive and his workup excluded any infectious or metabolic causes. So tacrolimus toxicity was considered the most probably suggested cause and accordingly was discontinued. Immunosuppressive regimen was changed into mycophenolic acid, 1000 mg 3 times a day, and prednisone 40 mg daily. All manifestation, including weakness, loss of vision, progressively improved with complete normalization in a couple of weeks. The patient didn't have any further deterioration of his vision, attacks of convulsion or weakness, and his follow-up MRI 2 weeks later was completely normal. So our final diagnosis was consistent with tacrolimus-induced posterior reversible encephalopathy syndrome. So what's a posterior reversible encephalopathy syndrome, or what's called reversible posterior leukoencephalopathy syndrome? It's a syndrome of clinical findings with characteristic neuroradiological findings that was first described by Henry et al. 1996. The pathophysiology is still not well clear, but the key factor is the development of vasogenic edema. There is 2 theories. First theory is elevation of arterial blood pressure that causing cerebral hyperperfusion, affecting the autoregulation, which causing disturbance for blood-brain barrier and vascular leakage, ending in vasogenic edema. And second theory is the cytotoxic injury caused by many medications or diseases that cause endothelial dysfunction and finally end in vasogenic edema. And this is a picture of vasogenic edema that develops with Brest syndrome. Actually, the exact pathophysiological mechanism is still unclear, and there is numerous etiologies have been reported, including the use of immunosuppressant medication, hypertensive encephalopathy, and eclampsia. Per's syndrome may present with one or combination of headache, nausea, altered mental status, blurred vision or vision loss, or seizures. These symptoms were found in combination with neuroradiological finding edema of posterior cerebellar white matter. Currently, there are no set diagnostic criteria for making the diagnosis of Per's syndrome. However, the characteristic imaging findings setting of the above clinical presentation are consistent with the diagnosis. Back to our patient developed sudden onset of left upper limb weakness, convulsion, and blindness up to no light perception, which is symptoms consistent with Per's syndrome, while on oral tacrolimus therapy, which promptly responded to discontinuation of the accused medication. Also, the patient didn't have risk factors for optic neuropathy, the bilateral nature and concurrent Per's symptoms, which resolved with cessation of tacrolimus, are consistent with tacrolimus-induced toxicity. It's also important to highlight that tacrolimus toxicity can occur even within its therapeutic level, as occurred in our patient. My take-home message: we portrayed the case of tacrolimus-induced side effect presenting with feature consistent with Per's syndrome. It's important to raise the awareness of the possibility of tacrolimus-induced Per's as a rare side effect following liver transplantation, even within its therapeutic level. Per's generally have a good prognosis. Prompt recognition management are important in preventing significant disease morbidity and mortality. Clinicians, including ophthalmologists and neurologists, should be aware of this association. Finally, we published this case report in an Egyptian liver journal by 2020. This is my reference, and finally, thank you.
Thanks, Dr. Abir. We'll keep the discussion till the end.
Coming to challenge 4, which is cholestasis post-liver transplant. As we all know, cholestasis is a condition characterized by defective bile flow or formation. It may result from an altered uptake, transfer, and secretion of bile components, mainly caused by liver injury in the absence of mechanical obstruction. Biliary complications are a significant source of morbidity in the early and long-term period after liver transplantation. Their overall incidence ranges between 15 to 25% with associated mortality up to 10%. They remain a major problem in the post-transplant patients. Timely identification and treatment play a significant role in preserving the graft and improving the overall survival rate of patients. Simply speaking, but the issue is not that simple, that cholestasis could be classified into extrahepatic due to mechanical impairment and intrahepatic due to impairment of liver cells or ductular dysfunction. Again, could be classified or reclassified into early, within 6 months, or late, more than 6 months post-liver transplant. But we have to know well that considerable overlap can occur. Simple look to this table, we can find that, for example, in extra and intrahepatic, there is the same reason, which is hepatic artery thrombosis. Again, comparing intrahepatic early and late, we can find that drug-induced as well as acute cellular rejection occurs here and there. So the overlap is actually great. So we have many, many questions to be answered. During the next part of our session, the questions to be answered are unexplained cholestasis and how to manage. And as regards surgical versus non-surgical interventions for biliary complications, the questions are: what is the role of endoscopist in management of biliary complications? And the radio intervention as a salvage route, what about it? And finally, what about the surgical reconstruction? The first question, which is unexplained cholestasis and how to manage, will be answered by Professor Maya Mahres. She's the head of Infectious Diseases Department, Armed Forces College of Medicine. She's also a consultant of hepatology and liver transplantation in Maadi Military Hospital, Dar el Fouad, and Sheikh Zayed hospitals.
Thank you very much for this nice introduction, and thank you for the invitation. I would like to greet our chairpersons. Thank you. I will just say it in short. Professor Mona saved all the time. I will not be long. Okay. Most of the complications we encountered Cholestasis is the most frequent complication after liver transplantation, and it has a very broad differential diagnosis. It may occur at any time throughout the post-transplant period, maybe intra or extrahepatic, maybe also classified as early cholestatic or late cholestatic within the first 6 months or more, and considerable overlap may occur. Within these time frames, both intra and extrahepatic may coexist. Let's formulate it in just a case. Okay, Mr. A was a 36-year-old gentleman. He underwent liver transplantation 6 months ago for end-stage liver disease for cryptogenic cirrhosis. He presented to our outpatient clinic for monthly follow-up, and on examination, he was deeply jaundiced and admitted that he was not very compliant for his immunosuppressants. His lab investigations at that time, his bilirubin was total was 12, direct was 7.5, transaminases were very high, 800 and more than 10 or 20 folds the upper limit of normal. Alkaline phosphatase and GGT also were shooting. Okay, so if we classify, if we want to clarify our differential diagnosis, we classify it as Dr. Mona said. Okay, it's maybe primary, early or late. He is above 6 months, so we will think about the other column, but also we cannot exclude the same causes of the early cholestatic diseases of the liver. Okay, primary non-function, actually this happens very early, not in this case. Hepatic artery thrombosis, the same. ABO incompatibility, this was not the case. Preservation reperfusion injury usually resolves within the first month. The small for size graft also, it appears earlier than this. So in this figure, it may show the symptoms for the early complications and how to manage them. As we said, the primary non-function, it manifests very early, immediately post-transplant, in the form of mild coagulopathy, oliguria, jaundice, hypoglycemia, and we cannot treat it, just needs immediate retransplant. For the preservation injury, as we said, supportive treatment that will resolve within nearly the first month. Small for size graft, the same, just supportive, and we hope it resolves. The hepatic artery thrombosis has many lines of treatment, but I won't discuss it now. There are radiological and medical. There are a lot of lines of treatment in this issue. The portal vein thrombosis, the same. Okay, biliary leak actually may not manifest by cholestasis or jaundice. Sometimes the patient has very normal serum bilirubin, but they can manifest in other manifestations, maybe an abdominal collection or something like this. Okay, and acute cellular rejection, there are abnormal liver functions, hyperbilirubinemia, and histologically is can be differentiated from any other cause of cholestasis. These are the early complications. In this case, in our case, this is not, none of these can apply. So we went for the late cholestatic causes of jaundice. Okay, causes of cholestasis, sorry, more than 6 months. If we go through this algorithm, we will start by ultrasound. If there is dilated biliary radicals, so we are dealing with an extrahepatic most probably or biliary complication with this patient. Okay, if there are not, we are going to proceed with the next steps. The most important of these steps that we shouldn't forget, and we have to be a little bit courageous to go for the liver biopsy. Don't be afraid and don't postpone it. Sometimes we get a little bit reluctant with these patients. Shall I take a liver biopsy? Let's wait to resolve. Maybe it will resolve. Let's raise the immunosuppressants or something like this. But liver biopsy at this stage is very, very important. And actually, it was very helpful in our case and other markers that we see. Of course, for, above the 6 months, we have the disease recurrence. This is also an important point that we have to know, that we have to be aware of the etiology of the transplantation. So we can be very careful and we can classify the patient in which of these classes he is. Also, the recurrence, the viral recurrence especially, is not only classified in the late cholestatic causes. No, it may be classified in the early ones, and we had these publications of the DAAs post-transplant. Actually, 2 patients of this series, this were treated in our center. 2 of them had a very early and severe fibrosing cholestatic hepatitis within the first months, and they improved. They had marvelous effect on the DAAs, and they are sustained virological responders up till now. Thanks God. Yeah. So the evaluation, back to our case, if we go through the same algorithm that we have seen, okay, he underwent an abdominal ultrasound and Doppler. They were normal. His MRCP showed no stricture or dilated biliary radicals. The FK level was not very optimum. It was 4.5. All the virology, CMV, HCV, HBV were negative. Autoimmune profile also was negative. And the liver biopsy showed only mild acute cellular rejection with no evidence of portal tract expansion or fibrosis. So we proceeded with him. He was admitted and he took pulse steroid. He improved, but very, very slowly. Upon discharge, we added MMF and his FK was raised and shifted to oral prednisolone and was tapered very, very slowly. Because when we reduced the dose, he had increasing enzymes. Along the next 4 months, the liver function tests were improving, but did not normalize at all. At any stage, whenever we do it, the liver functions, they're always high. After the 4 months, when we found that there is no marked improvement on such a regimen, and he was started to have side effects of the steroids and the elevated levels of the FK, so we re-evaluated and we decided to, as if we are going to repeat the workups since first step. So his late liver functions were 2.8, the total bilirubin, dark bilirubin was 1.5, and ALT and AST were nearly 10 folds normal, or 8 folds the normal. Okay, on the evaluation, we went all through, and the surprise and that we found the HB core IgG was positive and the PCR started to rise. He was never before positive. It was checked before, but it seems that after raising the immunosuppressants, it started to appear. His cytomegalo and HCV all were negative. So we decided to give him start entecavir 1 milligram. Within 1 week, all his liver functions dropped to normal. His bilirubin came 1.5, ALT and AST were nearly normal. Was not even 1.5 folds. Alkaline phosphatase and GGT also, they were reduced markedly. So the take-home messages that cholestasis, as we said, is the most common complication of post-liver transplant. Time limit or timeline is helpful, but we cannot sharply demarcate these complications. We have to be aware that recurrence may be early, rejection may be late, and they overlap all through. And as you said, etiologies may overlap. Explanted liver pathology is very, very important and of very big value. Screening by core IgG is very important, not only the surface antigen. And thank you very much.
It is a great honor to introduce Professor Dr. Sharif Megawer. Dr. Sharif is a professor of hepatology, gastroenterology, and liver transplantation. He's a board member of the Qasr Al-Aini Consortium of Liver Transplantation and was elected as an international member of American College of Gastroenterology and is a board member of the German Society of Crohn's and Colitis. His experience management of post-liver transplantation biliary complication. That's why he will address with us surgical versus non-surgical intervention for biliary complication.
Well, thank you, Mohammed, for this very nice introduction. And thank you, Professor Mona, for invitation, as well as Professor Mustafa Shazli for inviting me. My talk is already recorded, so if you can work it up from the side there, it will be great. And if you'd like me to work it from my side, it will be also fine. So kindly start the recording and let's see how it goes on. Bismillah ar-Rahman ar-Rahim. It's my pleasure to be with you today. Thank you, Professor Gamal Asadi and Professor Mustafa Shazli and Professor Mona Al-Amir for inviting me for this very elegant session and very elegant meeting. In the coming few minutes, I'll be talking on the role of endoscopists in the management of post-liver transplantation biliary complications. My agenda will include an introduction, followed by the causes of biliary complications. I'll talk a little bit about surgical issues, shortly about biliary leaks and biliary strictures, and I'll also differentiate between what we mean by successful rate of ERCP and biliary management, and what we mean by favorable outcomes. Future tools which may help us in a better outcome will be also shortly discussed. I will end up by a very short case. My introduction will be that will illustrate that this is the downside of liver transplantation, especially living donor liver transplantation, where biliary complication comprise at least 25% of the complication, which really affects the outcome of transplantation, whether the graft lost the quality of life of the patient, morbidity, and of course it needs a multidisciplinary team in order to reach a favorable outcome. The etiology of biliary complication is usually caused by technical complication at the site of anastomosis, ischemia or reperfusion injury affecting the biliary system, several types of mismatch, especially ABO mismatch, hepatic artery complications, donor age, and certain infections, specifically the cytomegalovirus. About surgical anastomosis, we know that there are two techniques which surgeons do. Either they anastomose the duct to duct, or they anastomose the hepatocochinostomy. I think that most surgeons will prefer the duct to duct anastomosis since it gives them gives us a technical feasibility of performing an ERCP once complications arises. Besides, it preserves the sphincter of OD function. And of course, they also can do it side to side or end to end. It's still preferred in 60% of cases. Hepatocochinostomy may be a must in case we have a size disparity between the size of the donor and recipient duct, as when a mother gives a kid or a father gives a kid, and also when the recipient duct is diseased, or in difficult cases where you find yourself among a lot of fibrosis and scarring. Example, if there is previous surgery or a retransplantation. There are some technical issues, of course, surgeons are always taking care of. They avoid dissecting at the 9 and 3 o'clock to avoid vascular decompromise. Suturing techniques and material have proved not to be effectively impairing or causing any cytopiliary complications. T-tubes and other draining biliary tubes are of course beneficial. They give us a route to do a cholangiography following transplantation. And there is a controversy that there could be a potential negative effect on the anastomosis, specifically when we withdraw these ducts after 2 or 3 months. Biliary leaks occur in 10 to 25%. They usually occur within the first month, while late leaks are rare. They occur mostly at the site of anastomosis, while rare sites are at the site of the T-tube insertion. Of course, they could also occur at the cystic duct stump and sometimes at the cut surface. They're usually managed by endoscopy as a primary care method of management. Minor leaks could be treated by a simple sphincterotomy. A significant leak may need stenting, while in case of hepatocochinostomy, still endoscopy has a role, which is effective and safe, but it's time-consuming and difficult, and you can compare in the image in the middle, showing you how it's difficult to identify the site of anastomosis, which in comparison to the image on the left side, you can see a well-defined papillae. In this case, you can only see a pinpoint opening of the anastomosis and a little mark that you have bile here. We overuse the double balloon enteroscopy, and it's not adopted by most centers because it's really technically difficult. Biliary leaks, especially the small leaks, are managed endoscopically or by PTC successfully in 80 to 90%, but put in consideration that any collections should be also drained using pipetades. Significant leaks will need surgical revision. And what do we mean by a significant leak? It's a leak where during injecting dye, during your ERSP, you can observe the leak before you can visualize the intrahepatic biliary level. This is almost the definition accepted by most of us. And usually big leaks, large leaks, will really need to be seen by surgeons and managed by surgeons as early as possible. Biliary strictures occur in 19% of cases, especially following living donor liver transplantation. They're, of course, divided into anastomotic and non-anastomotic, which could occur in cases of stones, Gauss syndrome, mucosal, and sometimes sphincter of organ dysfunction. Strictures are managed by a standard of care endoscopic management, which is usually the first line of treatment. And whether you do dilatation or dilatation and stenting, of course, dilatation and stenting is preferable and is superior, and it's recorded in most studies to have a lower recurrence rate, and it needs lesser sessions when they combine or when you combine the dilatation and stenting together. Success rate reaches about 75% of cases, and this meta-analysis shows that whatever you use, whether single, double, metal stents, percutaneous routes, all of these, you have favorable results. Of course, all of them are very successful, and it's usually recommended that you use more than one stent because it gives more favorable results than using a single stent. One of our studies have shown that we succeed in managing biliary complication in at least 75% of cases by endoscopic techniques. The highest success rate was for endoscopic approach in patients who had an isolated bile. Of course, in many of our cases, we had the help of our interventional radiologists using the percutaneous technique, plus an endoscopic technique, what we call the Radiological technique. Multiple sessions are needed, and we usually do this bi-monthly in cases of leakage. Metal stents give us the advantage of being larger in diameter. You need lesser or fewer sessions, and you get an outcome which is much better with lesser recurrence rate. Of course, there is no quite clear evidence of its superiority, but you can imagine the size really gives you advantage of preserving a good diameter of the bile tank for a long time. I would like to differentiate here between what we mean by success rate, which all of us talk about every time, success rate in the ERSP, but favorable outcome means something else. It's different. By favorable outcome, we mean that the patient symptomatically gets relief with more than 80% reduction in the total bilirubin and alkaline phosphatase. Of course, studies have shown that although we succeed in performing the procedure, we have unfavorable response in at least 50%, sometimes 80% or even more unfavorable outcomes in our cases of biliary complications. Unfavorable outcome seems to be due to an inaccurate diagnosis. So I think we need to use new metrics to improve our outcome. One of these metrics is used by the MRCP, in which you measure the ratio between the donor recipient, and if you get a ratio more than 1.15, then you have a specificity and specificity of predicting a favorable outcome. Of course, the RCP can also be used, and if you have this ratio of 0.8 between the donor and recipient duct, you have also quite a high sensitivity and specificity in predicting a favorable outcome. Some dynamic tests, such as delayed contrast drainage, which is more than 50% delay in contrast after you inject the contrast while you're retaining the contrast using the balloon above the anastomotic site. And if you find this in more than 3 consecutive fluoroscopic images taken at least 15 minutes after contrast installation, this gives you an impression that you have a delayed drainage, which means that you will have a favorable outcome of doing endoscopic dilatation or whatever method you use for dilatation. So my suggested algorithm would be in a patient to have a high liver function test, start by MRCP. If you get by the MRCP a duct recipient ratio, which is more than 1.15, then proceed to endotherapy, and you are going to have a favorable outcome. Well, if you have lesser than 1.15 ratio, then think of other things such as the drug effect, rejections, or any other cause of impairment of liver functions. But if endoscopy fail, which is a standard of care in most of the cases, we have to think of percutaneous drainage alone, or we can work and enjoy together doing the rendezvous technique, or sometimes, and in many cases, you may need surgical revision. Improving the outcome will be much better if we have more and more tools. One of these tools is the self-degradable stents, and in this study, a percutaneous approach was used to insert a self-degradable stent in a hepatocochinostomy, and it really gave a very favorable result. And you didn't need, of course, to go back and do another intervention to remove the stent, since it is a biodegradable stent. Endosonography sometimes could be helpful in cases which you cannot cannulate endoscopically. Spyglass, of course, could be very helpful since you can visualize the stricture, especially if it's associated with kink or it's a very tight or a narrow stricture. Visualizing the lumen, visualizing the stricture directly can guide the wire more perfectly to bypass the stricture, and you can have more successful results using the spyglass. At the end of the day, it's a multidisciplinary approach, and this is the only way to get a successful result. This is a case, one of the cases from the pediatric department of liver transplantation. A 3-year-old boy with a hepatorenal tyrosinemia. He received a left lateral segment from his mother in 2018, and he developed obstruction later on. And you can see from this MRCP how tight and how it was difficult to, in this case, we predict that this case would be difficult, but we can predict also a favorable outcome since you can see the ratio which is more than 1.15 between the donor and recipient duct. So we were expecting a favorable but a difficult case from the beginning. And here you can observe clearly how we were expecting this difficulty. We started by a dilator which could not pass, and later on we inserted a balloon, couldn't reach full insertion, and trials to bypass the wire also was very difficult. At the end, several trials successively succeeded by passing the stricture. Still, we were not comfortable that we reached a favorable dilatation, and in the same time, in the same moment, our radiologist was available, and he inserted his dilator, and we got a better result inserting a 10-French stent. And after this, the patient was in very good condition, and he is enjoying quite a favorable life. Conclusion: ERCP is the standard of care for post-liver transplantation biliary complication. It mandates a well-trained endoscopist, but we have to know that successful procedure is much different than what we call a favorable outcome, and we should aim at a favorable outcome, which means that we need new metrics to improve our outcome. Multidisciplinary approach helps to select a candidate for rendezvous or for surgical revision. ERC, although a standard of care, may not be always the starting procedure of choice. By this, I would thank you all, and I would like to end my talk. Thank you, and enjoy the meeting.
Thank you. Thank you, Professor Sharif, for this elegant lecture.
Thank you all. Thank you. Enjoy the rest of the meeting, and I can wait for the questions at the end of the meeting.
Sure, at the end of the meeting, the questions. Now it's my honor to present Professor Omar Abdelaziz, Professor of Diagnostic and Interventional Radiology at Cairo University. Professor Abdelaziz has more than 22 years experience in the field of interventional radiology. His main clinical and scientific interests are in the field of hepatobiliary, oncological, and liver transplantation pediatric intervention. He's a consultant of interventional radiology in 5 transplant centers in Egypt. Today, Professor Omar will present radio intervention, a salvage route. Please.
Good afternoon, everybody. I want to thank Professor Dr. Munna Al-Amir for inviting me today. I'll give a short talk on the percutaneous intervention radiological management of biliary complications after living donor liver transplantation. I'll skip the introduction. The main indication of percutaneous transhepatic biliary drainage is a failure of ERCP due to many reasons. The second indication is hepatocochinostomy, where it is usually the primary intervention. This is a 38 years old patient, 7 months post LDLT with clinical, radiological, and laboratory findings suggestive of biliary obstruction. The endoscopist asked for a rendezvous to be standby. So when do an endoscopist should anticipate difficulty or failure of ERCP from the first time? It requires high clinical sense of the endoscopist. I think they should rely on the kink in the presence of a major kink by MRCP or in long strictures after a long period after transplantation, which are usually hard to dilate and interfere. He might ask for the IR to be in standby. And this is the best scenario for the patient to do all the biliary drainage in one session. This is his ERCP failed to bypass the stricture here and the absence of opacification of the biliary radicals. Then percutaneous cholangiography was performed, and we can see here the site of the stricture and the common bile duct. We pass the stricture here by micro guide wire, and this is an advantage over the endoscopy, that we use a very small 0.014-inch guide wires, which are used in the coronary and the vascular system, so they can pass in very small and tight strictures. We dilate also with very small balloons, like 2 or 3 millimeter coronary balloons first. And then we can pass the guide wire to the duodenum. Then the rendezvous technique starts here, where the endoscopist snares the guide wire and can put the, usually they further dilate with 8 millimeter balloon, and then a stent can be inserted endoscopically. So advantages of a single session rendezvous technique is less morbidity and less hospital stay, single anesthesia, multidisciplinary, reduces complications of leaving an internal or external catheters. Also, the ERCP can choose a proper radical to place a single or multiple stents. It's also cost effective. Second case, a 58 years old patient, 4 months post LDLT with clinical, radiological, and laboratory findings suggestive of biliary obstruction. We can see here by ERCP that the anastomosis is very tight stricture here with failure to opacify the biliary system. Then we went by PTD here, percutaneous, and we passed the stricture, we dilated with the balloon, and then by ERCP, a stent was deployed. This 60 years old male patient, 8 months post LDLT with biliary obstruction. His first ERCP failed. In the second session, a rendezvous technique was performed. We can see here, we dilate the stricture here with a small coronary balloon, and then further dilatation by endoscopy, and a stent was deployed. The 2 sessions technique is a usual technique performed in different places because not all we start. Usually, you start with your ERCP first, and then when it fails, we arrange for another session of rendezvous. This is another case, a 49-year-old male patient, 4-month post-LDLT with biliary obstruction. In the first session, ERCP, they inserted a stent in the anterior duct. And then we went by BTD here from the posterior duct. We find segmental, in the second order branching, we can find segmental strictures. We have to dilate both segmental ducts. Otherwise, it would not be enough to dilate a single duct. So we went here by 2 punctures of the biliary system, the posterior duct, 2 punctures in the posterior duct, and we dilated with kissing balloons, sorry. And then the endoscopist put another stents in the biliary system. The posterior biliary system, we have 3 stents now. This is another case, a 57-year-old patient, 3 years post-LDLT with clinical, radiological, and laboratory findings suggestive of biliary obstruction. We can see here tight biliary stricture. In the first session, ERCP failed. In the second session, we succeeded to pass here the guide wire to the duodenum. We have 2 ducts. We have to puncture the other duct here, and we apply 2 internal external drains. We usually put internal external drains or external drains in cases of malignant obstruction, for example, as a part of the palliative drainage. Also in case of severe sepsis, where with severe cholangitis, where the stents will be occluded very rapidly, so we apply internal external. But in liver transplantation, I think it's not a good choice to leave internal external drains. It should be just a bridge to another rendezvous technique, maybe in the second day, for example. We don't leave it for a long time. We are usually not satisfied by leaving drains in the graft because of its complications like hemophilia, catheter dislodgement, tract leakage, local infection, and sepsis. We usually do this if it's not available to do a rendezvous technique for any reason, like an available endoscopist or an available machine, for example. But now mobile endoscopy machines are present everywhere, and it should not be a difficulty anymore. The other indication of percutaneous intervention, as we mentioned, is hepatocochinostomy. Our protocol in the different centers I worked in, we do sequential biliary dilatation over three sessions, in between 2 weeks in between. So we tell the patient that he will be treated over 1 month with an external drain, external internal drain coming out to be an access for the second session. Otherwise, it will recoil. If we dilate from the first session, it will recoil. So we have to do sequential dilatation better. And the more will be the better, but 3 sessions, I think would be enough. Another indication of leaving an external biliary drainage is the presence of severe infection, like in this case, we have severe abscesses at the hilum of the graft. So we prefer to leave an internal external drain for a while to drain the pus out. Can we apply multiple stents percutaneous? Yes, we can, but we do not prefer to do this because it requires multiple punctures in the graft, and it requires dilatation of the tract up to 12 French. So it's more invasive. So we prefer always to do it by endoscopy, not by percutaneous technique. In case of biliary leakage, number 1 in the management intervention is to perform drainage of the bilomas. In case of, this is a 45-year-old male patient, 2 months post-LDLT with clinical and radiological evidence of biliary leak. Hereby performed rendezvous technique by ERCP. You can see here the site of the leak here. And the guide wire failed to bypass the site of the leak. So we went percutaneous, a snaring of the wire and application of the stent. So this is the usual management of biliary leak after failure of ERCP. What about major biliary leak? This is a 56-year-old male patient, 1 month post LDLT with persistent biliary stricture. We can see here a major leak at the site of the anastomosis here. The endoscopy usually inflate a balloon here to give more pressure. So you can find the leak, and the endoscopist failed to bypass the leak to the biliary system. So we went by percutaneous route. We also failed to bypass the leak to the common bile duct. So we went to snaring of the guide wire in the false cavity around the bile duct. So if you can imagine that this area is raw, it's not covered, it's just a raw area outside the graft, and we see this the snaring of the guide wire. So it was successful, and a stent was applied here by endoscopy. Similar case also with a major biliary disruption. We snared the guide wire also from the false track, and the stent was applied. However, the endoscopy requires to remove the stent and exchange it every 6 months. We failed to exchange those stents because there is no track or no well-formed track in the bale area. So I think, in my opinion, that in major biliary leak, we should go immediately to surgery and not waste time and effort and money in complex interventional procedure. We, as they mentioned by Dr. Sharif Megawer, surgery, rapid surgery will be better. It's just we postpone the intervention. The indication of external biliary drainage in general is a failure of other techniques, of intervention techniques. We leave the biliary system drained until surgery. In conclusion, most of the biliary complications after LDLT can be successfully treated with interventional radiological procedures. The clinical success rates of endoscopic and percutaneous methods have been increased by novel ERCP and IRR techniques, better guide wire techniques, and improvements in the stent design. Moreover, use of rendezvous technique can increase the success rate in patients in whom one of the methods had failed. Thank you.
Thank you, Dr. Omar, for this elegant presentation. The next speaker is Dr. Karim Adel Hosni. He is a professor of liver transplantation and hepatobiliary surgery. Who will speak on behalf of Dr. Mustafa Shazli, the dear professor, is head of liver transplant team. He is unfortunately unable to be with us today, and Dr. Karim will speak on behalf of him.
Dear colleagues, thanks for, I'm sorry I'm not be able to attend with you, and Dr. Karim kindly will present the lecture.
Good evening, everyone. Alf salam al-hayk, Dr. Mustafa. I will, as asked by Dr. Mustafa, give this presentation, and he asked me to skip some of the slides which have been discussed by our colleagues and professors in the past few lectures. So I will try to just stick to the surgical aspect. So as Dr. Sharif said, we have a high incidence of biliary strictures, mainly leaks. في حتة مش باينة من السلايد. We need a multidisciplinary approach. So I'll not talk about the causes that have been covered. Site of bile leaks also been covered, and as well as the presentation. In this slide, we see that we should always try to use the less invasive methods, and It's and this we prefer as surgeons that the patient do some less invasive procedures first, whether that be conservative or by ERCP or PTD interventional. And when all this fails, then at that point it's justified to do a surgery, because surgery also has some of its failures. It's not a 100% solution, and it can sometimes be difficult. And in that case, we will do a hepatocochinostomy. But the point in this slide is that we may sometimes have to wait for 6 weeks before surgery. And the reason for that is that sometimes the patient has sepsis and the stump is not dilated yet, and as well as the presence of local inflammation. So all this will make us wait so we can do the surgery in optimal conditions and give the patient the best chance for the best possible outcome and the least incidence of complications. So again, this has been covered. What we'll be focusing on is mainly the anastomotic. The causes have been covered. Okay, and Professor Dr. Sharif talked to us about the risk factors, but we can go over this again. So some of the risk factors for biliary strictures, the surgical factors occur with the small and short bile duct stumps in the graft, multiple bile ducts, intimal damage to the bile duct by rough handling, poor blood supply of the duct due to disruption of the arterial circulation during dissection, performing ductoplasties, hepatic artery problems, long cold and warm ischemia times, ischemia reperfusion injury, and other problems as postoperative hepatic artery thrombosis. And some non-surgical factors also. Of interest here is how we try to, during surgery, prevent the occurrence of biliary problems. So this is obviously much better than needing to do surgical repair. And the two options are duct to duct, which, as mentioned, we prefer because it provides access for ERCP or hepatocochinostomy. So one of the things that can be done is avoiding excessive dissection of the duct and the right hepatic artery. And in this case, we will use the left hepatic artery to anastomose to the graft and not touch the right artery. And this is not always feasible because sometimes the left may be too small or too short or may have some problems, but if possible, that's one way. Okay, and in this, the T-tube. So we have different types. We can use the type of suture and whether we use interrupted stitches or continuous running stitches. There's been much debate whether we should use running stitches. Obviously may cause a higher incidence of stricture versus interrupted stitches, which may cause some leakage, and that may end up with a delayed stricture. So this is a good method to use And in this case, it's called the dunking with mucosal aversion technique. You'll see a picture of that. If we look at the black and white picture, the duct on the right, the common bile duct of the recipient, is everted. So all the stitches are not taken in the full thickness, they're just taken in the mucosa. And this will allow coaptation of the mucosa to the mucosa without any tissues going inside the lumen to cause strictures. So this is one of the very good techniques to prevent strictures. In this, the Glisonian sheath technique, the sutures in the liver graft are not taken in the duct, they are taken in the tissues around the duct, which is called the Glisonian sheath. And this is also a way to try and prevent strictures. And these are some of the advantages of this Glisonian sheath technique, especially with small ducts. We don't have to put sutures in them, we just go around them. Okay, and this is a picture of that, where the stitches in the liver side are not taken, as you can see in the picture on the top right, sorry, at the top left. Some stitches are taken outside the duct. So this provides a big anastomosis without narrowing the duct. Again, this is the same technique. A discussion whether we should use absorbable versus non-absorbable sutures. Some claiming that the absorbable sutures may cause some inflammation, which may assist in, while it's being absorbed, in the creation of a stenosis. Okay, we have talked about all these different algorithms from the management of biliary strictures, and we have agreed that the surgical revision should be the last resort, except as Professor Dr. Omar said, in the case where we can see that the interventional radiology will definitely not be successful. There may not be wise to waste time and resources and expose the patient to the risks of the procedures and go directly to surgery. But usually it's the last resort. Okay. All right, and so basically the same thing that's been covered. It's that surgical approach is indicated for patients with isolated short anastomotic strictures. I'll skip this, but we can see in the last line that in select cases, retransplantation may be considered. Non-anastomotic strictures covered by Dr. Sharif. Okay, before going to surgery, obviously we need to know exactly what we're dealing with. We need an anatomic evaluation, vascular assessment, and this is important sometimes, even though we know that the PTD will not be successful based on the MRCP, because there's a big distance between the donor and recipient duct, but still preoperative PTD is sometimes very useful, because intraoperatively during the dissection at the hilum, it may be a guide for us, and we can feel it with the fingers, the digital method, and then open right over it. And another advantage of having it is that sometimes we can use this PTD to put in our anastomosis, as we will see in the following slide here. So on the left, the PTD has been identified, and the arrow that says 2, that's the loop that will be anastomosed. And before the anastomosis, we put the PTD catheter inside, and it's left post-operatively for drainage and can be removed maybe 1 month after it. And in this slide, out of 273 patients, after a primary duct-to-duct reconstruction, 7.3 developed late isolated anastomotic strictures. 7 of these patients failed interventional biliary treatments and required surgical repair. Duct-to-duct reconstruction is feasible and safe. Surgical repair. Okay, so if the duct is possible to use, then we will use it for the biliary reconstruction. That's very unfortunately almost never the case, and usually you have to do a Roux-en-Y hepatocochinostomy. So the take-home message is that the bile duct complications are still a nightmare and challenging complication. A multidisciplinary approach is mandatory. Prevention is the most valuable way, and this is what concerns us as surgeons. And when problems happen, then the experienced surgeon applying the recommended guidelines for anastomosis and revision is needed. Thank you.
Thank you, Dr. Karim, for this presentation.
Before opening the discussion, I'd like to thank all our distinguished speakers, and I want to deliver special thanks to my dear professor and role model, Professor Sharif Mugawer, not only for his excellent presentation, but for his continuous support to me. I'd like to thank Professor Mustafa Shazli, the head of our team, and wishing him to get well soon. And I'd like to thank my dear professor and brother, Professor Ashraf Omar. Now the discussion is open. Any question from chairboard or the floor?
Can I ask a question, Professor Mona? I'm Sharif Mugawer. Can I ask a question?
Yes, of course. Of course, Professor.
I'll direct my question to Professor Omar. Endoscopically, we know what's the definition of a major leak, which means after injection of dye by an occlusive cholangiography, then you can visualize the dye before you visualize intrahepatic radicals. But when you do this through a percutaneous approach, how can you define that this is a major leak or a minor or a moderate, and whatever classification you use? I would be grateful if you just clarify this for me.
I think there is no definite classification for this by PTD, but it's just similar to what you have mentioned about visualizing the leak before visualizing the bile duct. Sometimes we fail to visualize the common bile duct during injection, so we know that it's a major leak. So we use the same concept as you have mentioned.
Thank you, Professor Omar. And could I also ask Professor Karim a very short question? Professor Karim, you have been talking that prevention is much, much better, of course, and is the most important objective is to prevent biliary complication rather than dealing with this tedious complication. So my question is, you offered a lot of surgical techniques such as dunking and in-block hilar dissection and the Glisonian sheath. I wonder if the Glisonian sheath would lessen the frequency of strictures, but would it increase the leak? I have this impression that it may increase the prevalence of leaks. Can you just explain this for me or clarify it?
Yes, sometimes it's not applicable, especially if the tissues around the bile duct don't have adequate strength, and then you would be worried to take stitches in these tissues, and yes, they may give way and then lead to leakage. But this technique is commonly used by the pediatric surgeons who perform the Kasai procedure, where there are almost no ducts that they can see, and they need to take the stitches in the hilar tissues or the Glisonian sheath, or even sometimes in the liver tissue itself. So to answer your question, it may sometimes not be possible, but yes, if you do it and the tissues are not good, it may lead to leak.
Thank you, Professor.
I will direct my question to Dr. Rasha Rifai. How frequent you will do a protocol biopsy for stable patients with normal liver functions?
Actually, in the adult group, we don't do protocol biopsy, but we used to do it in the pediatric age group. So for the pediatric age group at our center, they always do a protocol biopsy. And in this case, especially when I saw this case and I revised other cases, I started to think that we should reconsider this for the adult patients also, because after we have been transplanting now patients for 20 years, and we started to see such cases. And in the context that we are in a country that we don't have a cadaveric program, and we have too many limitations in the living donors. So I think protocol biopsy is very beneficial to avoid such cases. The astonishing for me in this case that the labs were completely normal. And when I did the biopsy, it showed that there is chronic rejection and fibrosis in some portal tracts.
Do you have any predictors you can depend on it? Criteria for the patient who will do the protocol biopsy, for example, if we are doing some sort of consensus or something like that, your message, we should reconsider again protocol biopsy in some patients. So do you suggest any criteria for these patients?
No, when you talk about protocol biopsy, you don't have any criteria. It's a protocol done by any center. They usually do for the pediatric age group a biopsy every year, then every 5 years after 5 years. So if you do a protocol biopsy, you shouldn't have a criteria for doing a biopsy. Usually we do the biopsy on basis of elevated liver enzymes or when we suspected a problem. But if you decide to do a protocol biopsy, you will do it for all the patients at an interval that is stated by your center or by the team. This is what I'm trying to reconsider. But if you depend on things that you choose the patients, it's not a protocol.
What I mean in stable patients.
Yes, in stable patients, if you do this in stable patients, as I told you, up to now, we don't do this in the adult group. It's done in the pediatric age group only. So my message is that should we consider this for the adults also? Because in the last years, I started to see patients coming to my clinic after they have been stable for a long time with normal enzymes, then presenting all of a sudden with ascites and graft failure. And I couldn't pick this at any one point because they were always stable and the enzymes were normal. So that's what made me think of the protocol biopsy.
Thank you.
Thank you.
Professor Rasha, before you go, I have a very short question, please.
Yes,
thank you at first for this very wonderful, challenging case. But at the end, how did you reach this compromise between immunosuppression in a patient with a high risk of reactivation of the tumor? And of course, in the same time, you cannot leave the patient with a chronic rejection. So your final decision was based on you are going to give immune suppression, but you're going to give it in a compromised way. So how did you end up your decision in this case, please?
Thank you, Professor Sharif, for the question. As you said, it was very hard because this patient has PTLD, and at the same time, I was afraid of the chronic rejection. He was young, he was 20 years old. That's why I started monotherapy. I gave him Advagraph, only 1 milligram. This is a very minimal dose. His trough now is around 3, from 2.5 to 3. So it's the lowest dose possible. And we're still at the start. I just started this 3 months ago. He's doing a very strict close follow-up for the PTLD. And I am planning to do him a biopsy in 6 months' time to see if there is any improvement in the biopsy.
Thank you so much.
Thank you.
Just a short comment, Dr. Rasha. I think the risk of PTLD or the rate of occurrence is decreasing with increasing age. It's more common in the pediatric age group rather than in the adult. Still there is a risk, but still is slower. So do you think you want to increase the immunosuppression slightly if the next biopsy still there is a chronic rejection?
Well, I will not increase it now. I will depend on the biopsy. If the biopsy showed improvement, I will keep it as it is. As you said, it's less than in the adult than in the pediatric, but still I have patient in the adult group that they had PTLD. But I'm not planning of increasing the immunosuppression for many other reasons, not only the PTLD, but he's young. I am always worried about the cardiovascular complication and the metabolic syndrome, the hypertension. So I'd rather keep it low so that the liver profile is normal until I see the next biopsy.
I think, Professor Mohammed, I think it's a matter of not the age of the patient, it's the duration of the immune suppression. So children and kids are exposed for a long time of immune suppression, they have a higher risk. But still, immunoproliferative disease is a very high risk in elderly population. So it's really a challenging problem.
It also related to the immune response. We are not dealing with a B cell as an immunosuppressive. As you know, dear professors, tacrolimus is blocking the T cell rather than the B cell, and the PTLD is related more to the B cell, which is more active, I think so, in the pediatric age group. So what do you think?
I agree, and also in this patient, he had his Epstein-Barr PCR was positive. Actually, we never did this in the adult group.
I have a question to Professor May.
We have prophylaxis against cytomegalovirus. Did we have a prophylaxis against Epstein-Barr virus treatment?
Actually, not even treatment for Epstein-Barr virus. We don't have treatment. We just stop the immune suppression.
Prophylaxis, like cytomegalovirus.
And no prophylaxis.
Because it is related. This patient related to Epstein-Barr virus. If we can go with prophylaxis to Epstein-Barr virus, like cytomegalovirus, I think we may decrease the risk.
But actually, there is nothing specific for the Epstein-Barr.
Right? Don't you hear about anything about prophylaxis Epstein-Barr virus?
No, actually not.
Okay.
Thank you.
Dr. May?
My question, did you revise the hepatitis B core for the donor?
For the donor, yes, it was negative. And the recipient himself was negative pre-transplant. And for the first time, as you saw the presentation, when we evaluate him for the first time, it was negative.
So it is acute infection?
No. So the IgG, it appeared after we raised the immunosuppression and he took the pulse steroid. It didn't show up before this. And it was very, very amazing case. Yes.
But it was not present before transplantation. This was my question. Before
transplant, during the first evaluation.
Sometimes there is a rare mutation in the hepatitis
Maybe.
surface antigen. It's very rare. The patient will not express the surface antigen.
Maybe.
So it could be a new infection, or maybe a fallacy in
His
the
core IgM
pre-transplant.
was maybe the first one was fault or was mistaken, but his PCR was also negative. But still, this is what's meant with the overlap. There were 2 etiologies for this liver function abnormality.
It might be a lab error. Might be a lab error.
Yeah,
might be a lab error.
Maybe the first time.
How can you explain the response to pulse steroids?
I don't know. He responded. It's an overlap. He had rejection, and when we raised the immunosuppression, the activation of hepatitis B appeared.
Autoimmune and hepatitis B virus?
Rejection.
He had rejection.
Before transplant, it was wrongly mistaken.
Maybe. I can't judge. But when we looked even for the explanted liver pathology, it didn't help a lot. This is why it was very deceiving case. Yes, it was very deceiving case actually. But what was very solid that he responded marvelously. Within 1 week, all his transaminases dropped.
Still, it's very rare even for reactivation of a previously exposed recipient for hepatitis B, because we are using hepatitis B core donor positive and recipient positive, and we have 0% reactivation. Despite we are using, of course, lamivudine as a prophylaxis, but still with aggressive immunosuppression and even using pulse steroids in different patients with rejection, we didn't see any reactivation. Still, as very
this one I remember very well, because his brother tried to donate him first, but his brother was core IgG positive, so he was rejected at first, and he brought another donor completely free. It was all the markers were negative. Thank you.
I have a question for you, Dr. May. For your case, I don't agree for the pulse steroid for this patient, because you mentioned that the biopsy showed mild rejection. And usually with the mild rejection, we start with increasing the dose of the CNI and then adding second line of drug and third line of drug.
Yes,
we don't go directly to
You are right. You are right. But he didn't
steroid.
respond. When we did this, he didn't respond, and his transaminases kept elevating, and this was very risky for him.
Yes, but I think this patient got acute B. I don't agree that it was.
No, it was. It was.
How did you know? Did you check if he went to a dentist? If he did any procedure? He can. Infection with B is very easy, and you can never tell if the patient had an acute or reactivation, because you mentioned that the core was negative before transplantation.
Core IgG, his core IgM was negative all through.
Yes, so all his markers were negative.
Yeah.
So from where can the activation come?
When he took the pulse steroid, or we raised the immunosuppressants, maybe it happened, or it was a lab fallacy for the first time. I believe that the first time when he came negative, I think this was not negative.
Okay.
But his PCR was negative the first time. When he was evaluated for the first elevation of liver function tests, they were all negative. PCR was negative.
And you didn't think of repeating the biopsy after the pulse?
We did. And it came it was the rejection improved, and no other signs for hepatitis. Neither hepatitis B was detected, nor autoimmune de novo. We thought about for de novo autoimmune hepatitis. It was negative for all this. And I didn't mention it because it was very also deceiving. He, on our land, he responded very well for the anti-hepatitis B.
Okay, thank you.
Okay, thank you.
Can I have another question to Dr. Abir? Or the time is out of time? ممكن نلحق نسأل? Okay. Dr. Abir, you mentioned you stopped the FK or tacrolimus. Did you shift or try to shift to cyclosporin or other CNIs, or or the patient will be kept on MMF alone?
Okay. Our patient, once we stopped tacrolimus and shifted to MMF with increasing the steroid dose, he completely responded. Okay. With the follow-up, patient course passing very smooth. So we suspected this tacrolimus is the only drug that accused in this syndrome.
Yes. As you mentioned, it is dose independent to this side effect, but for how long you will keep the patient off of CNIs?
The patient following up till now, and the patient passing very good course and very good labs.
Only with MMF?
I think
only MMF with steroids.
This will be difficult.
And this is your plan to continue on only MMF and steroids?
We are still up to now. In the last follow-up, we do not reassuming the tacrolimus. Maybe in the next follow-up.
I think you should consider another primary immunosuppression, like sirolimus maybe, but I don't think it's enough to maintain the patient on an MMF and only steroids.
Okay. In the next visit, we will detect the follow-up.
You will not return to tacrolimus anymore.
Okay. Add another immunosuppression. Okay.
Because it's quite short, about 3 months, I think now.
Yes.
It is very early.
Okay.
If you have a patient with a neurological toxicity and he passed a few years and he is now on cyclosporin and he is now had a rejection, acute rejection. So do you refer to return back to tacrolimus after many years of neurotoxicity resolution? Do you think he will experience again neurotoxicity?
But we can shift to cyclosporin.
He's already on cyclosporin and he rejecting in cyclosporin. Okay, we'll add another emitters or whatever.
Neurological complications was very far away for years, or even he had psychological side effects, neurological or psychological. I will not return to the accused drug because, as Dr. Ali mentioned, it is not dose dependent, so it can occur again.
Okay.
Dr. Mohammed, I have comment for this. Actually, I faced this condition, the patients who had psychosis or depression or neurological complication for the Deprograph, and we shifted them early to cyclosporin. Then after a year or more, they had rejection and I needed to shift to the Deprograph. I did this, and in those patients, when you resume the drug after a period of time, I didn't see these neurological complications. Most of the patients who had neurological complications, it's immediately after transplantation. Maybe this is related to the encephalopathy that the patient had before transplantation. But when you resume the drug again after a period of time, I didn't experience these neurological manifestations again.
I think the explanation that the neurological toxicity is an idiosyncratic effect of the tacrolimus. But the nephrogenic effect of tacrolimus is intrinsic toxicity related to the dose.
Yes.
So the idiosyncratic effect of the drug toxicity could happen or could not happen.
Could not happen again.
But the intrinsic toxicity will occur.
Will always happen.
Will always occur.
Yes.
So that's the explanation.
This
is the bridge between the opinion of Dr. Iman and your suggestion.
Yeah. Okay.
I have two short questions to the chair board and the floor. Is it the time to apply protocol biopsy in our centers? Agree or disagree, please?
Yes, I agree.
Agree. We all agree to apply protocol biopsy. We have to take the decision. Okay, then my second question, have you ever diagnosed? Further?
I am conservative.
Still conservative, gray zone. But most of
depend on some clinical.
Most of us agree, Muhammad. We have to. My second question for staff from or professors from other centers as regards PRESS syndrome. Have you ever diagnosed a case of PRESS in your centers? No cases of PRESS. We have to consider. Do you agree with me? Okay, تفضلي. Thank you.
دكتور ناهد مخلوف من اسيوط. وحضرتك كان في حالتين يعني توقعنا كده، يعني حاله برضو بعد الزرع فتره جالها انكفالوباسي، واحنا ما لقيناش اي سبب تاني اللي كانت يفسر الحاجه دي، فاحنا توقعنا انه ممكن يكون السندروم دي. في حاجه تانية بقى، كان في حاله انا كنت بس هسال الدكتوره عبير عليها، كان حاله يونج ايج لسه، كان اوتو اميون ليفر ديزيز.
اتفضلي يا دكتوره عبير.
هي اوتو اميون ليفر ديزيز، وبعد زرع على طول دخلت في كونفالجن، واحنا عملنا لها يعني السي تي والام ار اي فينوجراف ارتيروجراف كان نورمال، وكانت دخلت في الفيتس، يعني هي كان دخلت فيتس وما لقيناش اي سبب، ولا الالكترولايت كانت نورمال والسي تي والام ار اي كله نورمال. كان جاست ان هي كانت بادئه تاكروليماس يعني 2 دايز، وكانت تاك ليفل جاست 2. يعني ما كناش عارفين السبب ايه، هل هي ممكن تكون الحاله دي ولا يعني السبب
هو البريس سيندروم is a clinical symptom مع نيوروراديولوجيكال فايندنج، لازم نيوروراديولوجيكال فايندنج. اتوافق معايا دكتور عمر، لازم يبقى فيه لازم يبقى فيه فايندنج، في تابيكال فيتشرز وفي اتابيكال فيتشر، بس لازم يكون كلينيكال نيوروراديولوجيكال. ديفرنشال دايجنوستس بتاع البريس سيندروم از وايد، في حاجات كتيره ممكن تتشابه معاه
يعني لو نورمال ايميجينج يو كانت دايجنوز.
ما اقدرش اقول ان هو بريس.
اوكي ثانك يو.
دكتوره عبير، عايزك توضحي لهم ان البيشنت بتاع البريس in our protocol was we are keeping the patient under follow-up, but we will totally change his immune suppression protocol in the nearby visits. But of course, we will not dare. We saw a complication which was in a severe, extreme form of complication. So I think that even if it's an idiosyncratic, and we may expect after time it will not occur again, but I myself, and I think all of those involved in treating this patient, will never dare to repeat cycloneurin, and we will change into another protocol, probably MMF and everolimus later. Thank you.
Thank you.
Do you agree with me, Dr. Abir? We have to suspect PRES in any post-transplant patient with neurological manifestations? Do you recommend suspecting PRES in any case, or you have your limitations?
Should be in the differential diagnosis.
Yes, هو زي ما أنا قلت no set diagnostic criteria، لكن PRES should be suspected if clinical symptom consistent with PRES plus neuroradiological finding. Yes, it should be in differential diagnosis.
I'm expecting that it's underdiagnosed because not diagnosed before in many centers, and I have to put it as a possibility and think of it to diagnose it. It's my opinion. Yes. I don't know if you agree with me or not. Before closing our session, I'd like to thank you all, and please stay to take a photo with us. Thank you.
طلع بروفلاكسس اللي بيشم الفيروس. لا في صور كتيرة صور.
بجد بجد والله بيجري بقى اول مره بروح ساعه في العلم اول مره انا هفكر بقى اكتب بعد كده. لا بجد انا سعيده والله بجد ده يعني بجد واضح انه احنا في كده روح حلوه ما بيننا اصلا يعني مش كده عشره شكرا ليكم والله شكرا ليكم ان انتم يعني في الجو ده وفي الاومايكرون وفي اللي احنا فيه ده بجد يعني من غيركم ما كانش هتبقى السيشن ومرات ثانيه يعني والله
حاول نزلك حاجه خليني محمد شاكر غريب والدكتور دوري بقى
اليمين تبع انت تبع البطنه العكس احنا برضه بطنه باين يعني طبعا الصور لا انا بطنه انت الاول ما تجيش على مراوح بس احنا عملنا بقى الميكس ده بقالنا 17 سنه فاحنا زمان طبعا في ايشوز ما بينهم لكن احنا بنشتغل مع بعض ان شاء الله ما تبقاش اخر مره بجد والله يعني لا بس برافو يعني برافو بقالكم قد ايه سنتين تقريبا بداتوا بالراحه شويه وبعد كده سرعتوا والله طبعا ما حدش لا بس حلوه حاجه بس خدتي المديرة يعني انت تفرغتي وخدتي المقابل انا فاهمه زي الدكتور عندنا كده رئيس الفريق ان شاء الله لو هتعملوا اي اكتيفيتي مش بعيد انا طالعه طريق سياحي ربنا يخليكي بذوقك يا حبيبتي شرفتينا اشوفك على خير باذن الله أول مرة تقريبا لا بس أنا سمعت اسمه يعني